Alrighty, so hello everyone and welcome to today's session of the Lunch and Learn Seminar Series with Teach. Today's faculty presenter is Dr. Peter Selby, and he'll be presenting on the implications of cannabis on tobacco interventions. Too much.
Thanks everybody. Welcome to everybody from both Ontario.
Thank you, Tanya, and thanks everybody. Welcome to everybody from both Ontario, and I saw somebody is there from Manitoba, and from wherever else you may be joining us today. We seem to have about 202 participants on this webinar signed in, so that is really amazing. At least 200 sites, so you're part of a large group, and I'm going to try to make sure we get through everything from here and that we meet your needs in sort of learning about this controversial topic. Okay, so if you want to get a letter of completion for this webinar, you know what you need to do. Register for the webinar, complete the learning assessment, sign in to view the live webinar session using your first and last name, complete the post-learning assessment, and voila, you have a Lunch and Learn webinar letter of completion. These are being live tweeted on our Twitter feed at PS Quit Smoking, so feel free to follow us there, and the hashtag is #TeachWebinar. So feel free to tweet as you're listening, and as well, and so we'll be doing that as well. Okay, so you can see at the top right hand corner of the screen there's the web. Okay, I can hear somebody else on the phone, but I'm going to ask Tanya to manage those calls. Anyway, so that's who I am, but I'm the chief of the Division of Addictions and a professor here at the Department of Family and Community Medicine, Psychiatry, and the Faculty of Medicine. Okay, financial disclosures. This talk is not being sponsored by anybody other than the Ministry of Health and Long-Term Care, but these are my potential disclosures and something that you might want to know of. The one disclosure there that might be relevant to the topic we are talking about is some of the work that we've done with the pharmaceutical companies that make smoking cessation medications, as well as the companies that make medications for the treatment of marijuana dependence as well, or potentially for marijuana dependence.
If you are on the teleconference line, to mute your line, just push *1 on your phone. We are getting some background noise, so please do so. *1, yes. Great, thank you. Sorry, Peter.
*1, yes. Great, thank you. Sorry, Peter.
All right, so any potential bias that there may be, hopefully we want to make this information accessible and available to all participants at the time of registration and the presentation date. I'm going to skip through this because we went through this and just get to our learning objectives of this hour that we have together. One is we want to just increase the understanding of people of how Canadian youth use marijuana and what their perceptions are of cannabis use, because as we know, most addictions start in adolescence and then become problematic when the person is much more of an adult. Of course, some adolescents themselves get into trouble with it. The other one is just describe what the current Canadian policies are on medical marijuana and what is the association between medical marijuana use and nicotine dependence, and what can we do sometimes when it pragmatically comes up against our hospital or healthcare system kind of rules. We also need to recognize the general adverse health effects of cannabis use, and not to say that all of it is harmful all the time, but again, to put it into perspective. And comprehend the current correlation between concurrent cannabis and tobacco use. One of the areas that we find and we see clinically, and many of you on this line must be seeing it, is that there's a relationship between cannabis and tobacco use. And again, managing it when people are in withdrawal or being treated, or when managing relapse, it's paying attention to both those substances simultaneously. And then can we apply similar skills to those who use cannabis, not necessarily from the medication side, but from the aspects of behavioral treatments and goal setting? Okay. So why is this discussion important? As you know, CAMH came out with a sort of release, a policy release, suggesting that currently we have 500,000 Canadians who've got a criminal record for use of cannabis, and that the current policies are not working. And what we recommend is a strong regulatory policy while making it legal overall, and getting away from this issue of illegal cannabis and people getting into trouble with it. But let's take a look at what do Canadian youth think about cannabis. This is a report released by the Canadian Centre on Substance Abuse, and you could visit that site, their website, for more information if you like. When you take a look at youth who were surveyed in 2013, what they will say to us is that the positives are, which is interesting, but they believe it helps them focus. Now, is this because they are relaxed and they're less anxious, so they can focus? But they also talk about helping them sleep, improving their creativity, and in thinking it may help their mental health, as well as they have this belief that it's medicinal properties and cures cancer. So that's what they think. On the other hand, they also realize that it can cause dependency, so that it's not addictive in their minds. They do feel that it can cause dependency. They also realize that it can cause loss of focus, even though some people think it helps people focus. They attribute it as a cause of laziness, but also they feel that it can affect people differently. So they balance both of those sort of issues when they make that decision to use or not use. From an illicit substance use perspective, it's the most common illicit substance use. If you take a look at the Canadian Alcohol Drug Use Monitoring Survey of 2011, in 21% of youth aged 15 to 24 reported using cannabis in the previous year. Now, this doesn't mean that they are all addicted, but they reported at least single use. Despite declining cannabis use trends since 2008. So although it's getting less and less, this age group tends to be the highest users of cannabis. And if you compare to those over the age of 25, you can see that it is at least almost 3 to 4 times as much in this younger group. And that is particularly concerning to us, because we know that the adolescent brain is much more likely to get addicted than at any other period in life. So the young exposure to the young brain can set it down a trajectory that can cause lots of troubles. So I can hear somebody on the phone, so if you don't mind muting your line by pressing *1, that would be greatly appreciated. And then despite this, we want to also take a look at this. Students aged 15 years have the highest rate of past year cannabis use in 2009-2010. So there's an issue that cannabis use is starting young, and as young as 15. And so, this is now happening in high school, early high school, as opposed to in university, and it's at a critical time where people's trajectories in life are being developed. So that's the current thing, that there's a misperception. It's medicinal, it's safe, it's not addictive, and we and there's a greater chance of using it. And again, you're beginning to see youth using marijuana first before they graduate to tobacco. So it may also be working as a reverse gateway, and we'll get to that in a bit. So where did medical marijuana or medical cannabis come from? In April, it's an interesting thing. If you look at how during Prohibition times in the 20s and 30s, at that time there was medical alcohol, and it appears that we are using medical marijuana in the same way. We're having the ability to create a condition. It doesn't matter what the evidence suggests or not. There's a medical loophole by which people can legally access marijuana. And so in April 1st, 2014, marijuana for medical purposes regulations came in, and basically there are commercial licensed producers who could become the only means to access medical marijuana. And people who would be eligible to get this medical marijuana would be obviously at the end of life, if you've had spinal cord injury, seizures, epilepsy, spasms, weight loss or nausea from cancer, HIV, anorexia, cachexia, severe pain. Again, if there's a specialist who declares that this is, you could have it, then therefore you could get it. So they, obviously have to create some criteria by which people could get medical marijuana. But when one looks at the evidence base for this, it's very poor. And in fact, although the marijuana that is being sold has high potency right now, most of those studies had very low level potency marijuana, like 9% or less. And so looking at the medical marijuana laws right now, it's an interesting way of coming back at this whole idea of marijuana being illegal. But from a medical perspective, it is really a problem. And I think, as Gary Goodwin here on this says, what about the level of THC content versus that in the 17s? Absolutely. People are getting really strong levels of marijuana at relatively low cost. So vulnerable individuals could potentially become dependent very quickly or get into trouble with developing, for example, psychosis if they're at risk at a very young age. So, I don't want anyone to leave this thinking that marijuana is not dangerous, but the best way to regulate it may not be to make it illegal. There may be other ways for us to start looking at this. But anyway, coming back to the topic here, medical marijuana, people will get it. People are getting it either through compassion clubs or they're getting it through their doctors signing off. And here are some of the things about what its implications are for people who get dependent on tobacco or nicotine. So rats exposed to marijuana will self-administer nicotine more readily and made more efforts to acquire it than saline-exposed rats. What does this mean? In this study, it's basically saying that, which is mimicking what kids are doing now, starting off with marijuana, that this might actually for some be the gateway onto getting onto nicotine. So, and they also consume a greater amount of nicotine. So there may be something there, at least in animals, and you can say that, well, this is a predisposed animal to getting addicted, because if that were the case, they would be, putting the saline up as much as well, and they're not doing that. So, I guess we just need to start typing a little bit. What do you think are the implications of medical marijuana on the treatment system, the prevalence of use, cannabis dependence, and nicotine dependence? So feel free to start typing in quickly, and then we will move on to the next section, and I'll respond to the comments that come in. So if you can just type in, then I'll start looking at it. Already I can see that Gary is saying, is it not there are 4 times the tar in marijuana? Yeah, when you have a joint, generally there's no filter involved, and so depending, and many people obviously co-mix tobacco in that joint, and so when you're doing that and inhaling deeply, the exposure of tar, and the tar is all the products of combustion that are solid that are being deposited into the lung, minus the water and the nicotine. It can be quite substantial, and again, this is variable depending on how the joint is prepared, how big it is, how long people hold it in, etc., etc. And so again, a take-home message is that any kind of combustible vegetable matter that is inhaled, that is lit and smolders and then is inhaled, is going to generate carbon monoxide and many polyaromatic hydrocarbons that get inhaled and then cause problems. So I'm just going to roughly walk through some of the topics and comments that people have typed in. Is this a gateway into addiction? First, many people will say, well, most marijuana users don't graduate to something else, and many people talk about, marijuana is what people land up in, and then they give up other drugs using marijuana. So I think the question is, it depends on whom. for some people, it certainly is a gateway, but it's not only a gateway, but it's polysubstance use that goes on. But we do know that the probabilities that somebody to go on to using drugs is greater if they are marijuana users than if they are not. But the animal studies seem to suggest it might be getting people to, predisposing them to like drugs more. I mean, this is that great, a guest has said, wonder what the rats would do instead of having saline as a choice, they had sugar water. Would that change their choice of nicotine? And that's a great question. I can't answer that question, but I will look that up and see if there's anybody done that kind of study. But that's a great one, whether they would do that. And if it in fact is a reverse gateway, it will likely have some rebound in the rates of tobacco smoking. I mean, as it stands now, smoking rates are sort of plateaued, and we seem to be in an endemic state where the number of smokers coming into the system are equal to the numbers leaving. And so we're at the steady state in the country, and you're right, we need to see what impacts this would have on smoking rates. And clearly the impact, as you said, when there are all these beliefs around marijuana and there's medical marijuana, it makes it harder for teens to think it's not good for them because it's a medicine after all. All right. Other issues that came up that people have said is, a good question, does cannabis attach to the same receptors as nicotine? No, but the cannabinoid receptors, our brains have receptors for cannabis, actually interact very closely with the nicotine receptors in our brain. And in fact, at one point, there were drugs being developed that would block these receptors for cannabis. And in fact, blocking those receptors for cannabis was associated with reduction or stopping of smoking as well. It's just that that line of drugs has stopped being developed because it made people suicidal. So, clearly there may be other drugs that will come. But those two receptor systems are not the same, but they're linked very closely. And clearly people do report having a better effect when they mix cannabis and tobacco. All right. So, all right, there's implications about trying to even disprove that marijuana causes all these diseases or helpful for these diseases is problematic, and here is therein lies a problem. One of the issues is vaporizing cannabis versus smoking. Clearly, that has certainly been some things that people have gone to, and with medical cannabis, lots of people want to have products that instead of having to smoke it, they want to either eat or drink it if they're going to have it. So, there's some lessons to be learned from what's happening in Colorado and know what not to do, but you are seeing various alternate forms that do not involve combustion. Okay, so the implications are we need to make sure that young people at least know that both those things are potentially addictive, and there are risks to that, and clearly we do not want kids to start using marijuana either. I mean, although it is overall less addictive than nicotine in the sense that long-term use is less likely than compared to nicotine, you still don't want to have that exposure in a young brain because it can prime them for other addictions to marijuana, as well as mental illnesses such as schizophrenia, especially if they are vulnerable to that. Okay. And anyway, so moving on, we'll get to some of the other questions as we go on. When you look at cannabis use across Canada, you can see that there are certain parts of the country where there is heavy use. Obviously, BC is very high, followed by Alberta and Ontario, and less so in moving in the prairie provinces, and then obviously out east. Now,
I'm just going to go ahead and mute all the lines. So when I do this, you are going to have to unmute your line again.
Okay.
In just a minute. minute.
So do I need to hit star 1?
Yes, star 1. So I'm going to push star 5 now to mute everyone, and then you push star 1 in just a moment to unmute.
Okay.
Conference is now in silent mode. All participants muted. Line unmuted.
Okay.
Mute your line.
All right. So coming back, the adverse health effects that we know that cannabis use, and most of it is smoked, is when you look at the short-term use, again, we have to pay attention to how a person takes it, whether they smoke it or eat it, and their previous experience with it, and the setting in which they use. A lot of this experience of it is very context dependent, and not all people get the same effect. But generally, what has been reported is, obviously we know that it has, impairs attention, memory, motor function, cognitive function, coordination, balance. It decreases the blood pressure, increases the heart rate, and clearly this is the short-term effects are dangerous, obviously, with respect to injuries and falls and driving and snowboarding, etc. That are not exactly a good idea to be high while you're doing these things. So the short-term effects clearly are impairing it. The long-term effects can be, extensions of the short-term ones, but as we said earlier, increased risk of psychosis, depression, and anxiety. And clearly for those who smoke and inhale cannabis, lit cannabis or burnt cannabis, things like bronchitis, airflow obstruction, diseases like emphysema, or where they get bullous disease, or things like these air pockets in the lung become problematic because of the way people inhale and hold the smoke in. And of course, because of contamination of fungus and other things like that, and bacteria, you could get something like Legionnaire's disease. Lung cancer has also been associated with this. It's tough to parcel out how much of it is cannabis smoked itself versus tobacco, because almost all of them are dual users. And then again, there are reproductive effects on potentially slowing fetal growth, fetal malformations, and fetal cognitive functions. But when compared to tobacco, it's tough to separate that out. In fact, in some situations, it has actually failed to show any of these effects on the reproductive effect. And so how much of it is smoke versus if the woman ate the marijuana, whether that would have any impacts is unknown. Now, when you look at this, we talk about the comorbidity. Cannabis use and abuse and dependence are more common in those who smoke tobacco than those who have never used tobacco. So it appears to me that actually protecting people from both cannabis and tobacco protect the person from each other. And again, and it's not just smoking tobacco, it happens with smokeless tobacco in the second bullet, as you can see. And generally, if people are using both cannabis and tobacco, they're much more likely to actually be classified as having a use disorder, which means they're more likely to be addicted as opposed to just using it occasionally. And clearly, if they're using tobacco and they're seeking treatment for their cannabis, their cessation outcomes for cannabis is less likely to be successful if they are also concurrent users of tobacco. So as we are beginning to see the story, they tend to interact with each other and affect the outcomes of both. So, and again, now this first bullet basically says that if somebody is using substances of abuse like both smoked and smokeless tobacco, they're more likely to be meeting criteria for cannabis as well, cannabis use dependence, because it could be that this person is just seeking out drugs of abuse and doesn't matter which way they're getting it, they just want it. And again, I mean, this is just more of the same, that just to prove that actually from an association perspective, these drugs go together. Now, we've talked about this chicken and egg issue, and the problem with this is that tobacco use in the past used to often precede cannabis use. But now we're beginning to see that cannabis use may be preceding, and clearly there are many ways for us to think about this. There's obviously this idea of gateways of drugs, but there's also the reverse gateway where people start cannabis first and then switch to tobacco. Another equally good explanation could be that there could be a genetic predisposition in some people, and they get to whatever they can get to first, and then they just keep going to try the next drug that they can get their hands on. And it may be one single or a set of genes that makes that person much more likely to use drugs. The other possibility is that the route of administration can be quite similar, which is both smoking. So the person has tried how to smoke, they know how to hold smoke, they know how to light a cigarette or a joint. And so they do that. And then in the using culture, there's a lot of co-use of both. And so even if the person initiates with cannabis, it's very likely that their first joint, most people don't roll their first joint, they get a joint from somebody else. That person may have had tobacco in it, and that might happen. The overlapping environmental factors, so we know substance use as well as tobacco are much more likely to be used by those who come from social disadvantage or poverty or less education. And we also talked about the receptors of nicotine and cannabis talking to each other, leading to this. And lastly, the economic factors. So as we look at why people get addicted, we have to take a look at that there are biological reasons as well as environmental reasons and social reasons why they do that. Okay, so this is a very difficult slide to see, but if you take a look to the lifetime co-occurrence of cannabis and tobacco use, you can see how, as I just mentioned, the genes may be common. A route of administration is also an issue. So we just basically went over this, and the slide is just basically giving a model of how they might be correlated and in how people use both tobacco and cannabis together. Now, withdrawal is an interesting one. Withdrawal from both cannabis and tobacco in the 70s was, was imperceptible except in heavy daily users. But remember, the purity of cannabis back then was maybe at 7-8%. Now you're looking at maybe 15 to 20%, quite high, maybe even higher depending on the type, and much more variation with THC levels versus cannabis levels, and the cannabinoid levels. So even when people are smoking, depending on the strain, they may be getting various effects, but when they stop it, you're not sure what you're seeing. What we do know is that when people stop both together, people tend to be more irritable, angry, and more aggressive. But you also, withdrawal associated with dual abstinences is less severe than withdrawal from either drug alone, which is odd because people may be saying, well, one may be countering the effects of the other. So it is unclear, and I think we have to just pay attention to that individual who's coming up to us, and that's what we try to do, is to try to figure out what exactly they are withdrawing from. In many cases, we talk about it, we'll actually start with a nicotine replacement and sort of ask them to, if they're still, switch to either oral forms of cannabis, which doesn't have tobacco in it, or if they insist on smoking, really look at getting them away from both drugs simultaneously, because if you keep doing the hand-mouth motion with lit product, it's very likely you're going to go back to smoking your tobacco as well. One of the problems we have right now is the co-treatment of cannabis and tobacco smoking as one research study has not been published, hasn't been done. It's often because studies tend not to take people who use two drugs at the same time and try to do an intervention. It's a messy study to do, but we do need to get those studies done. In general, the big question becomes, should you do it simultaneously, where people simultaneously quit both drugs, or should you sequence them? Given the lack of good evidence, overall we try to do both drugs at the same time, but clearly one has to bring in client and patient choice into this. And so one of the things that we often tell people is that, look, if you've been smoking joints which have tobacco, everything you smoke and where you smoked is going to get triggered. So if you're going to continue to use just smoke cannabis in the same places, your tobacco withdrawal is going to feel worse. You're going to miss the tobacco more. You're not going to feel right. So you may want to consider doing both together. What it does appear overall in substance use is that by giving up both together, it doesn't appear that it affects the outcome of either one. So, it isn't that marijuana is a good treatment for nicotine withdrawal, or people should smoke marijuana instead of cigarettes, or vice versa. So, one of the things is that, again, this is a complicated diagram, but it's basically, again, from this study by Agarwal et al. Actually, this article by Agarwal et al. That basically, what do we know? We know that if people continue to use tobacco when they're getting treatment for cannabis, these are the things that will happen. They're much more likely to go back to to tobacco, and lower probability to quit tobacco, and lower likelihood that they will maintain the abstinence. So one of the things is we do recommend that people do things together, and again, assessing cannabis use and the interest of quitting both cannabis and tobacco use simultaneously generally should become routine. That we should assess it. I err on the side of saying try to quit both together, but if the client is really, or the patient is really insistent on not quitting both, then looking at switching to alternate forms other than smoke forms, and then coming off the cannabis later on. So when we look at the extant literature out there, we don't have evidence for treating both together, but we look at tobacco and we know there's good evidence for that, and that's behavioral and pharmacotherapeutic interventions. And for cannabis, there's evidence for behavioral treatments like CBT, contingency management, motivation interviewing, and motivation enhanced therapy. So in essence, if you look at it, CBT and MI have this transdiagnostic approach. So it would be reasonable to think that if you applied this to somebody who's using both tobacco and cannabis together, it will make sense. It doesn't appear that any of the pharmacotherapies that we give people will make them want to smoke cannabis. So I think combining these two things becomes a reasonable way to approach this. Now, the other aspect, so that's the idea, is to put those things together. The second thing that we have to pay attention to is relapse. And with relapse, I think one of our concerns is that co-users relapse to cannabis, whether they were smoking tobacco as usual or were recently abstinent. So essentially, it could be that these people are much more heavily dependent. So it isn't as if you quit tobacco right away that somehow you will get a protection from relapse from cannabis. I think relapse to cannabis is often because people underestimate the addictive nature of it. Many times if people quit cannabis easily, they'll say, it's not that addictive, I had no problem stopping it. But what people don't realize is that just because you don't have problem stopping it doesn't mean staying stopped is going to be easy. So the best, but again, cannabis relapse, we know if people are smoking, they're much more likely to go back. So the literature is a bit messy. So how do we make sense of it? How we make sense of it is, absolutely, if people can quit both, that's great. If they continue to smoke their cigarettes, but they've stopped cannabis, their likelihood of relapsing to cannabis is higher than if they had quit cigarettes. Although they may still relapse, it's just, it's less likely. So where do we need to go with this? I mean, we clearly need to test tobacco cessation interventions specifically in cannabis-dependent individuals, and look at it whether it needs to be simultaneous or sequential. Simultaneous means both at the same time, or you quit one first and then quit the next. But important to determine whether patients who seek cannabis and tobacco cessation treatment who successfully quit smoking cigarettes reduce their cannabis relative to patients who fail to quit cigarettes. So there may be a harm reduction aspect to this, that generally we know that when people reduce their tobacco use, their other substances go down. So for example, we know by just reducing the consumption of tobacco, people's alcohol consumption actually drops as well. So in fact, even smoke-free bylaws has led to reduced alcohol consumption. So it would be interesting to know with cannabis whether a similar thing happens. In the other end, if you think about it, we work in the business of smoking cessation. So our behavioral interventions are about stopping smoking. It's not, specific to tobacco per se. And so could we broaden that as a skill set that includes tobacco and cannabis? It doesn't matter if you're smoking something, you're helping somebody stop the act of smoking. And then the pharmacotherapy is a different matter, but clearly is that something that we should look at. And again, we need to start looking at, many people are missing people who are highly functioning, people from the 60s who are working, and they're having symptoms of respiratory symptoms or mental health symptoms, and people don't ask them about their cannabis use. We've had that happen time and time again at CAMH, where these people in their 60s and sometimes in their 70s who are having mental health symptoms, and no one bothered to ask them about their cannabis because they're a nice little old lady. They don't look like people who be using joints, or that somebody was a lawyer working at Bay Street. Doesn't look like the person, but make no assumptions. People use, and so it's important to ask, because as people are getting older, they're potentially having these kinds of symptoms. So therein lies the overview, roughly, and of that. And in this, I'm going to just now get back to some of the questions and the discussion points that we've had. Is this. The first thing is, when we're doing the assessment for people, is as part of our assessment, we find out about the use of marijuana. How much, when, what format, medical, non-medical, and what benefits and harms are they experiencing from that. So that's one domain of questions. The second domain of questions is, what is the relationship between their tobacco and marijuana use? And in their readiness, where are they? Are they concordant, ready to quit both together? Quit one first, quit one next? Switch the modality from inhaled forms of cannabis to oral forms of cannabis? And then share with them the sort of incomplete literature that, look, if they quit both together, their chances of doing well are sort of better in the long term, but not to underestimate the difficulty they might experience when they quit. But then we are there to help them and to apply behavioral treatments for both their cannabis and their tobacco, and then apply the pharmacological treatments for smoking cessation. The pharmacological treatments for cannabis have not been approved per se, but people do use them off-label in inpatient settings, for example. So somebody gets admitted to the hospital, they can't go be smoking the medical cannabis. We do give them Marinol and other kinds of drugs like that to help them manage those symptoms. So that's an overview. So I'm just going to now scan through the questions, and I'm just going to go backwards because it's easier so that I don't lose track. Actually, no, you know what? That may not be the wisest thing to do. So let me go back to some of the questions that started. I think that Jan had the question, what have we learned from Colorado and Washington? What we learned from Colorado, and Washington is watching Colorado, is just don't make an open market without regulations where cannabis can be advertised, sold, no place, and then now you're having some of the poisonings and kids getting into trouble. Certainly we don't want the Colorado experiment repeated. What you do want is a highly regulated market where you do your best to make sure that kids have limited access to it. You'll never get it down to zero, but that they have limited access to it, and that the adults who get it are not landing up with criminal records, etc. And again, Lindsay is saying that treatment setting with youth is to reduce or quit means picking what is realistic and manageable. Often teens choose to quit one over the other versus both. And I think that's the issue, right? Is making these small gains. And if the most important thing is keeping the person engaged in the process. Focusing on the quit too soon may disengage the person from care. And you really want to make sure that you're keeping that person engaged. And sometimes progress might seem slow or not going anywhere. And I think you may just need to work with that person to make the small incremental gains. It might be just a 10% improvement and reduction in both, and some observation that they're getting something better. So we agree with whether it's youth or even adults, is that slowing down our intervention to what people can manage and tolerate is actually often an important one. Keeping people engaged, continuously working with them, trying to focus them or evoke from them their reasons for changing are critical ways before you plonk a plan of quitting onto them. So great point there. Yeah, and I think this whole idea of people getting medical marijuana willy-nilly, whether there's young, right now, the way the law is, once you get your medical marijuana exemption, that there's no monitoring. There's no follow-up required. The person can go, and if somebody's willing to sell them the marijuana, that's fine. There's no real follow-up, because once you've got that, sort of, it's like a ticket. Once you have that, the doctor is not sort of refilling the prescription or anything like that. It'll go, you just get the authorization and you're off to the races. So it is interesting that there may be some long-term effects, and some, it's not well publicized, but there are some examples where this might actually lead to significant harm for some people. And so that's the problem. I mean, young people who start it can get really problematic, get real big problems with it. And so I think right now people seek out medical marijuana, and clearly it doesn't need to be that easy to get. It needs to be really thought out. People should have really well thought out reasons. Prescribers need to have well thought out reasons as to why they're going to prescribe it, for how long, and for whom. John said, is vaporizing marijuana safer? If you mean that it doesn't have the products of combustion, yes, but we don't know currently with illegally manufactured marijuana, we have no idea what else it's contaminated with, both chemically as well as biologically. And so right now there's no sort of quality from that perspective, but yeah, it doesn't have the products of combustion that you would get with a cigarette. For medical marijuana, has it been conceived to add the THC to the nicotine cartridge and the nicotine inhaler? I don't know if anybody's conceived it, but we certainly have seen e-cigarettes, where, especially the second generation e-cigarettes, the higher voltage ones, where the head can be changed and can certainly be used to vape marijuana. So yeah, there are always people like that who could do that. Yeah, okay, Gary asked that from the ends. Yeah, absolutely. There have been these adaptations, and it's they actually get a kind of waxy kind of product that they put in there that helps heat it to the right temperature, and they're able to use it for that purposes. For the patient with mental health issues, is it important for the healthcare provider to be aware of marijuana use? Absolutely. Marijuana use, often this is what happens. People use, especially people with psychotic illness, they'll use marijuana, they'll get really psychotic. Sometimes their first psychotic episode, they get admitted, they don't have access to marijuana, they clear up nicely, and they get discharged. As soon as they get discharged, because nobody's knows about the marijuana use, or has told them not to use it, or has put them, got them engaged in a program for recovery, they go back out, they use marijuana again, they get psychotic again, and they come back again. And that cycle seems to repeat itself fairly often. So the healthcare provider really needs to know if somebody is using marijuana, and then assess the severity and clearly get them a treatment, because they're going to be in trouble if they don't treat that. Yep, and I think Kristen has really said that. We see this perception that kids see that if it's medicine, it can't be that harmful. But I think we need to get that myth broken, because medicines are harmful, especially when they're given to people who don't need them. So I think we have to, get, now unfortunately the government ads have been a bit off, they've been a bit off, because, the research that suggests that people lose IQ may be questionable, but what people do really need to know is that, look, in the short term, yes, people may feel good and relaxed and calm and may not appear to be that impaired. It's the long-term issues of what happens. So yeah, today you may not be impaired 5% or you may not perceive it, but you keep adding that up over years, your life takes on a different trajectory, and you'll never be able to trace it back to the fact that you were toking up your entire youth. Because it's imperceptible. It doesn't it's not like alcohol or opiates, so you're immediately intoxicated and immediate risk of harm. With this, it's unusual. No one dies of an overdose of marijuana. They don't die from that. They may do silly things, or they may, be paranoid, but it's pretty much they're not getting aggressive, violent when they're intoxicated. So people tend not to appreciate the harms that it causes, much like tobacco, right? I mean, smoking a cigarette immediately does not cause you harm. It's the long-term and repeated use of it that is harmful. So I think that's important to keep in mind. Okay. Why was Nova Scotia? I'm going to go back to that slide to see if I can actually blow it up and get you a better version of it. It's looking really tiny on my screen. Yeah, and it's an interesting issue. Is marijuana use in the Maritimes so high? Primarily because universities or young people be more honest. It's tough to know because these self-reports, it's often these surveys are of people who have phones, and so we have to take these things into consideration. I guess it's really looking at the trajectories of the trends as well. Okay, and yeah, I mean, cancer deaths related to smoking pot. These are the things where you have to look at associations, right? And even the tobacco, so the association, the strength of association, causality is a tough one to prove. And you're absolutely right, Heather, that it could be the tobacco itself causing that effect rather than the marijuana itself. But so the question is, there is a signal there. Is it actually causing? We'll need more study. Yeah, the prenatal effects are not often communicated because it is controversial actually, but I think one would not recommend that people toke up as a way to manage their morning sickness when there are alternatives. Now, I don't know if you've been watching the news. The whole thalidomide issue came out, and what we do know at least is that marijuana is not like a thalidomide, and I'm not trying to say that, but that people should use marijuana. But I can understand why people would say, well, even medicines cause such harm. What we do know now is we do have medications like diclexin and others that can be used safely in pregnancy and have shown and demonstrated minimal harm to the fetus and even much later in life. So I think, but I can understand why some people do not trust us, do not believe what we have to say, and will toke up and smoke marijuana while pregnant. And again, I think the issue about whether if the partner is smoking, it's the secondhand smoke exposure that the woman gets exposed to. So that is one of the concerns about any exposure to smoke. And so generally for pregnant women, we say, try to hang out in the healthiest possible environment you can for most of the time. That's good for you, will be good for the baby. So keep an eye on yourself, and if it's good for you, it'll be good for the baby. Water pipe use also increases the problem for both tobacco and marijuana use. Yeah, essentially it does, but water pipe use is an interesting social phenomenon that we're beginning to see in young people. And the question is, we tweeted this yesterday, one session on the hookah essentially exposes you to the smoke exposure of what you would get from 100 cigarettes with respect to carbon monoxide, etc. Jan has a great question about breastfeeding with marijuana users. What is the effect? I can't say that I know offhand right away. but it will transfer into the breast milk, and the question is how much of it will get along. The question, so I don't know the answer to that, and I don't know if anybody else does, but marijuana and breastfeeding, I'm not sure it's recommended, but we'll have to look that one up. Third-hand marijuana smoke, I can't say. I mean, I think there is. I mean, any smoke that gets left in an indoor space becomes third-hand because and then off gases. It's important. Okay, where are we at? Yes, so observing people who use marijuana for a long time suffering panic attacks, what is your opinion? Absolutely. If you take a look at cannabis and the marijuana plant and what people use, there are compounds in cannabis that they say will actually reduce anxiety, but there are other compounds that make people more anxious and have more panic attacks. So, you know, when we see these drugs, people need to understand that if they're getting to get more and more anxious, that it may actually be drug induced. Although they'll say, you know, when I actually have my marijuana, I calm down, but it could be that they're actually getting more anxious. It's like, you know, people who smoke tobacco, they often will say, well, cigarettes calm me down, but often when they quit, their anxiety levels and panic attacks sort of get under control. Okay. All right. Right. Thank you, Laura, for bringing that up. Marijuana is concentrated in the breast milk at 8 times in plasma, and yeah. So yeah, so thank you for that, and you got that from Up to Date. So thank you. Yeah, yeah, can't be good. So let's go back up to some of the other questions. So medical marijuana comes in dried marijuana, basically, and that people can then do what they will with it. So it can be used exactly how street marijuana would be used. The regulation is trying to make sure that people get some consistency in what they are doing, and see what we, you know, it'll be interesting to see if they can meet those kind of quality guidelines, and that one product to the next product will actually have accurate dosing levels. And the question then becomes, does it even matter? But I guess one of the biggest issues is one of the biggest issues that we face is the products of combustion. So anyway, so I think we need to think about this carefully. I think we need to when we're looking at people who are using marijuana, we really have to get down to what they're using it for and how much misinformation is driving this issue. So anyway, coming back to some of the questions. Are the long-term effects of depression and anxiety reversible with cessation? What are the treatments of depression and anxiety related to cannabis use? You know, this is a great question, because what we don't know sometimes is substance use flipping a switch in this person earlier for something that was subliminal, like depression and anxiety, and will they respond to medications? Now, we've had with drug-induced psychosis, sometimes people don't respond as well to medications, and that psychosis doesn't go back even after they stop using drugs. And sometimes you see these people who will be depressed and anxious even long after they stop drugs, and it is part of that depression and anxiety. And you'll do your best to treat the with CBT, environmental shifts, as well as medications, if necessary. Even in the use of medications, what we're trying to do is use medications that at least you know what the side effects are going to be, and don't have, and you're weighing those risk benefits. The overall idea is to get to functionality. So it is an issue that It's a good question. I don't think we have the answer to that. Heather also asked the question, would reverse gateway theory apply in a situation where youth is using a different substance like cocaine and uses marijuana to aid reduction and cessation of cocaine use? Is it a gateway out? Absolutely. I mean, those are things that we've heard people say, that they, I've quit my heroin, I've quit my cocaine, I'm using now to marijuana, and then I'm on my way out. People do all sorts of things to help them get better, and it's an intriguing one. Motivations to stop using drugs tends to often come from outside, and they get internalized, and so how the person goes about it is up in the air. I mean, everybody uses non-evidence-based, whether themselves, they try to do what is helpful to them. But it's an intriguing question. I can't say that it is an issue. Can withdrawal from cannabis provoke seizures? This is a great question. In general, no. So it's not like people stopping alcohol, where alcohol withdrawal seizures occur. Cannabis withdrawal seizures are not known to occur. However, there are people who believe that marijuana is useful and can be used for the treatment of intractable seizures. So in those situations, cannabis withdrawal would provoke a seizure. However, not sure you can generalize this to everybody else. The question about whether NRT will support adverse withdrawal from both drugs when quitting, I can say yes or no, because withdrawal has both a biological basis to it as well as a situational basis to it, because withdrawal symptoms, we know, can also be precipitated in the person who knows they may have access to a drug and then it's taken away. And you can precipitate withdrawal just by that experience, that anticipation can create a withdrawal state. So I think it's prepping the people that, okay, you are on NRT, that might help your nicotine withdrawal. Whether it's going to help with the cannabis withdrawal, which tends to be non-specific for the most part, is up in the air. Okay, thank you for that comment, Judy, and I'm going to go on for some of the next. And thank you, Aaron. Given the limited success alcohol regulation has in terms of limiting access to youth, I wonder how regulating cannabis would prevent youth from accessing any further. I think, Jackie, you make a really good point about this. And the issue is taking a look at the overall risk that occurs to society. I mean, if the current access laws, and 40% of youth are using it, we have a lot of people who land up with criminal records. Maybe we need to think about another way of approaching it. And you're absolutely right. I mean, youth will access drugs of abuse. The question is, can they do it in a safe way without it leading to harm to them? So I think that's an empirical question, and it'll be debated for a long time as to whether the current format that we have, which is banning, is actually causing more harm than good. Okay, so what is a hospital supposed to do when there's a long-term medical marijuana user is admitted for a significant period? In general, there are oral formulations of cannabis that can be used, and so you don't necessarily have to let the person smoke cannabis. And we have to see those. We've had people talk about it. There used to be a drug called Marinol or Dronabinol in Canada that is no longer available or manufactured for sale in Canada, and so there are other cannabinoids that can be used. One which we are studying is something called Sativex, which is a spray, but it's extremely expensive, and we have to be careful with that. I mean, but and we're studying it as to whether it'll be a good option. Okay, we are crossing time, so I will have to say I should conclude this right now. We like all your questions. What we're going to do is To the ones we didn't get to, we'll basically create an FAQ and try to get back to you and post them somewhere on the Teach website if we can, and make sure that people have access to the information they're looking for. And of course, you're more than welcome to get the slides. I think you can click on, if you go over to your right-hand side of your screen, you'll see something, a box which says slides. You can click on it and thereby download them to your desktop.
That's my fault, Peter. I'm sorry.
And I want to thank everybody, and I want to thank Tanya for arranging this. And I'm sorry my screen did not work.
Yes, everyone, as Dr. Selby said,
Yes,
please
that's my fault.
continue to type
No,
in
no.
your questions. Alternatively, you can
Okay.
email your questions directly to me, and we will do our best to get
So,
to all
yes, everyone
answered.
has continue
We
to
will
type
send
in your
them to
questions.
you via email, as well as
email your
post
questions
them
directly to
on
me, and we will do
to
our best
Teach
to get
website
them
in
all
the
answered.
archive section.
We'll send them to you
So
via email, as
thank
well
you
as we'll
everyone
post them
for attending
onto
today's
Teach
session,
website
and
under
thank
the
you,
archive
Dr.
section.
Selby, for a very
So,
interesting
thank you everyone
presentation.
for
Now
attending
remember, a
today's
link to
session.
the
Thank you,
online
Dr.
course
Selby, for the
evaluation as well as the
presentation.
post-learning
Remember, a
assessment
link to
2
the online
will
course
be
evaluation
emailed
as well
out
as the post-learning assessment
likely
2
tomorrow
will be
morning,
emailed
and you
out
will have 1 week to
likely tomorrow
complete
morning,
the
and you will have
post-learning
1 week to
assessment.
complete
And
the
again,
post-learning
that is
assessment.
required in
And
order
again,
to
that
receive
is
the
required
letter
in
of
order to receive
completion.
the letter of
If you
completion.
participated
If you
today as a
participated
group,
today as a
please be
group,
sure to
please be sure
email
to
me
email
by
me
end
by
of
end of
day
day
today
today
with
with
the
the
full
list
list
of
of
participants.
participants.
Now, the
Now,
next
the
lunch and
next
learn
Lunch and
webinar
Learn
session
webinar
has
session
not yet
has
been
not yet
confirmed,
been
but we're hoping
confirmed, but
January
we are
2015,
hoping end of January 2015, and
and
the
the expected
expected
topic
topic
is
is
toxic breath.
toxic
Please be sure
breaths.
to check
Please
back
be
on our
sure
website
to
in the
check
new year
back
for
on
our
our
updated
website in the
schedule.
new year for our
And
updated
happy
schedule.
holidays from the Teach
And
Project. Thank
happy
you
holidays
everyone
from
for
the
attending
Teach
today.
Project. Thank you everyone for attending today.